Well, I'd go back to the notion that our national organization talks about mental health for all. And I really think mental health for all should be our guiding star. I didn't mention some of the health promotion programs we've developed over the years. We've certainly developed a great capacity to provide programs that improve people's quality of life for people with complex mental health issues, with addictions, people involved in the justice system, people who are homeless. Um, and I think what makes that happen is the fact that there are evidence-based programs that we can draw on, that we can use as a platform for innovation. So, for example, um, because of COVID, we switched to a lot of online support. And for example, out of the drop-ins, routes and pathways, we had peers doing mental wellness checks with many of our clients who couldn't come in. And we've been doing counseling sessions over the internet. But at the same time, we also developed a very impressive um, testing capacity for service users and staff, which means that as COVID happens, um, we can get there quickly. And we've also been able to test clients and staff in other agencies. And again, that's because of the commitment of our nurses and our nursing leadership. So I think what makes a difference is understanding that there that mental health and providing good mental health services isn't um, a thing that nobody knows how to do. In fact, we know how to do it. We've been doing this work for some of it for over 40 years since community mental health programs were established. There's an evidence base that we can draw on. And there's the experience that people have providing the services that will allow us to both question things that um, we need to when things don't go as they can, and that's where the work that Garfield and Frank and all the staff and particularly the managers and directors have done around quality improvement and quality assurance. That notion of let's understand what the program logic model is here. What are we trying to do? Are we getting there? Are we having an impact on reducing hospitalization? So, for example, we know that province wide, assertive community treatment teams over 6 years can reduce hospitalization by about 82%. You can go from 50 days down to 10. Doesn't mean that you totally reduce hospitalization, but you certainly can have a dramatic impact on reducing most people's hospitalization over time. And not only that, assertive community treatment teams in the province were able to establish a bit of a benchmark where about 65, 66% of their service users weren't even admitted to hospital within a year. At CMHA, our standard is in excess of 80%. So 80% of our clients don't have a hospital admission. And then through the stepped care programs that we developed in Scarborough and are now starting to roll out in North York through the Northwestern Toronto OHT, that notion of being able to flex services up and down according to people's need is really, really important. The ability to integrate nurse practitioner services in to provide help with the primary care issues, because we know that people with complex mental health conditions are often at risk of things like diabetes and heart disease and cancer. And in fact, when we did an analysis of that some years ago, we found out that most of the people who were unfortunate enough to die in our service, and it's not a lot of people, it's around 20 or 30 people out of 9,000 people that we serve every year, but 80% of the time they were dying from physical health issues. That spurred us to begin to develop a primary care capacity that Jennifer Pettigrew and her colleagues lead, and including things like Act Now and Smoke Stoppers. So again, it's the can-do attitude of the CMHA staff. I mean, we sort of analyze what are the challenges, what are the opportunities we have to sort of change the script for people, and then we just let people do it.